UBC, inspiring Uganda.
You are watching the DOCtalk Show.
Good evening, ladies and gentlemen, esteemed viewers, fellow seekers of knowledge. We welcome you to this episode of the DOCtalk Show, brought to you by Quiz Mali Productions and sponsored by the Ministry of Health of Uganda and its partners. My name is Dr. Muyanga Andrew Mark, and I am your host tonight on the journey into the world of medicine. And in-house, we have two guests who are here to enlighten us about the topic of the evening, which is palliative care and its place in the health sector. Allow me to request, starting from the gentleman on the far left, that they introduce themselves to our audience.
Thank you very much, our moderator. I'm Dr. Mwanga Moses. I'm an assistant commissioner in charge of under clinical service. I'm in charge of palliative care and hospice. I'm happy to be with you to share with you about palliative care.
It's a pleasure having you.
Thank you so much.
And the lady right next to me, please say hi to the audience.
Hello to you all and greetings. My name is Lisa Christine Irumba. I am a palliative care clinician and a pain specialist. I serve at the Palliative Care Association of Uganda as the research and information manager.
Thank you so much. It's a pleasure having you, Dr. Mwanga, in-house, and Lisa. It's wonderful to have you. From your introduction, we hold confidence that we shall not be left the same. And I think from what you said you're a palliative care specialist. I think we shall start from that point because I would like my father, my grandfather, hidden deep in Bunyole sub-county probably to understand what palliative care is. So Lisa, what do you mean by palliative care?
So thank you very much. Palliative care can be defined in simple terms, but there is a medical definition. But for my grandmother and mother in the village, palliative care is comfort care. It is an approach of care that is given to patients who have any form of serious health-related suffering, or any person that has been diagnosed with an illness that is often incurable and long-term, with a goal of improving their quality of life. And this palliative care is holistic. It does not look at just the physical problems of this person, but it looks at their psychosocial issues or emotional problems, their spiritual issues, their social issues, and in that, it could also be their cultural issues, their beliefs and values that could affect the sort of health they receive. So in terms of physical problems, it could be the usual things like pain, symptoms like nausea and vomiting. But in psychosocial or emotional problems, it could be the fear, the anxiety that comes along with being worried about being diagnosed with this condition. And usually when people are sick for a very long time, they ask why me? Why did this happen to me? Is God punishing me? They're looking for a meaning, and sometimes most of the time they want someone to listen to them and talk about these issues that are affecting their soul. And that way they live a good quality of life. And palliative care does not just focus on the patient, but also their family. You want their family to understand that this is the problem that's happening And this is what we are doing as a palliative care team to improve the quality of life of this person such that they live a dignified and comfortable life.
That has been really deep and yet so easy to take in. I thank you so much for the effort you've put to share that with us. But then coming to you, Dr. Muwanga, how does palliative care in this case differ from curative treatment?
I think to add on what my colleague has just shared with you, palliative care improves your quality of life. It may not be prolonging life. You know, when we are giving people curative care, you are aiming at curing that what caused the illness. But in palliative care, your aim is basically to improve the quality of life that person has. It may be years, it may be months, it may be days, but how does that person live? The depth of that life, that little life that person is left to live, that is the main aim of that palliative care. And as my colleague said, palliative care is given to those people who have chronic illness. Once you get a chronic illness, you just know this illness, you're going to live with it, it's life limiting. An example, people always look at cancers, but these days we are looking at the NCDs, the non-communicable diseases. Once you get diabetes, you get hypertension, you get sickle cell, you know you're going to live with this illness. As soon as a diagnosis is made at that time, palliative care comes in. Simple things like making the person understand counseling is part of palliative care. It's improving you as a person as well as the caretakers to appreciate that, fine, this person has got an illness, but he can live with that illness, you know? So that counseling is really required, the psychological, making that person appreciate, especially the caretakers, because in many cases we look at the person who has the illness, forgetting about the caretakers.
I was actually going to later ask about caregiver burden.
Yes.
Because most times you are looking after someone with a chronic illness. As you've said, we often look at the person
who has the illness,
challenge,
but we forget about the family.
We forget the physical
Exactly.
and emotional toll it is taking on
True.
them, but we shall certainly come to that part.
Yes.
So Lisa hinted on something which is important, because so many of us have often thought about palliative care just from the physical perspective, but then from what she says they handle the biological aspect of a human being, the psychological,
Yes.
the spiritual,
social.
and the social
Exactly.
as well. So it brings us to the next question: who provides palliative care, especially within our context?
Yes. So palliative care is provided by a multidisciplinary team, because when somebody is sick, they have a whole burden of problems. So everybody has a role to play. I'll start with the healthcare team. So you need a doctor on the team. You need a physician to diagnose the problem, but also give expert knowledge to the patient and family to help them understand the problem and the life course and journey this problem will take, and what they should actually expect. We have a nurse. A nurse provides nursing care, but a nurse spends most of the time with the patient. They do a lot of communication with the patient and their family. We have a psychologist, we have a counselor, we have a social worker who will manage the psychosocial issues, network this person with other organizations that can contribute to the care, but also bring light some of the aspects that people could have ignored. We have the spiritual caregiver or the chaplain. So this one will heal this person's soul. So the body is sick, the mind is sick, the soul is sick. So it cannot be a one show for one person. A counselor, a member of the community who will check on this patient if they are back at home and say, there's a very sick person there, it would be nice that they benefit from, you know.
So from what you are saying that this is a multidisciplinary venture.
Yes.
It's not a one-man show.
Yes.
At the end of the day. Allow us to have a short commercial break, and we shall be right back to continue the discussion.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show.
Tuliko ground, Plascon, paint and win. Yes, yeah, Plascon, paint and win. Tuliko ground, Chicho, buy paint worth 100K. Get a scratch card, SMS the code to 7197. Stand a chance to win instant airtime, 1 million shillings bully day there, or a share of a 3 million shillings jackpot each week. What do you want the brand new podas, tuk-tuks, and so much more. Catch the paint and win action every Monday on Bukede One, NBS, and Sanyuka TV. Plascon, color your world.
Busitema University informs the general public and all its students who qualified for conferment of degrees and award of diplomas and certificates of Busitema University that the university will hold its 15th graduation ceremony on the 29th of November 2024, starting at 8 a.m. at Busitema main campus in Busia district. The provisional graduation list is available on the university website www.busitema.ac.ug. This graduation ceremony will be broadcast live on UBC TV starting at 10 a.m.
You are watching the DOCtalk Show.
This
DOCtalk Show.
Good evening, our viewers. Welcome to the DOCtalk Show. This evening, we are airing from Masaka Regional Referral Hospital. I'm Dr. Mary Nyantaro, a consultant pediatrician, and I'll be your moderator for this evening. With me in the studio, I have my colleagues. I'll request them to introduce themselves.
Good evening, viewers. I'm Speciosa Amoit, and I'm a nursing officer, Masaka Regional Referral Hospital, and I'm the nurse in charge in the NICU, the neonatal unit in the hospital. You're welcome to the show.
Good evening, viewers. My name is Dr. Sheila Oyela. I'm a consultant pediatrician working at Masaka Regional Referral Hospital. You're most welcome to the show.
Thank you. This evening, the focus is on Masaka Regional Referral Hospital. Masaka Regional Referral Hospital is a tertiary hospital that provides specialist services to the region comprising of 9 districts. We serve the districts of Kalungu, Bukoma Nsimbi, Kalangala, Sembabule, Masaka, Chotera, Rakai, Liantonde, but we also receive patients from PG, Gomba, Butambala, and also serve one city, that's Masaka City. This comprises of a population of close to 2.6 million people. In this community, we provide a various number of services in pediatrics, and I would call upon Dr. Sheila to take us through some of the pediatric services that we support the region with.
Now, the pediatric department offers a wide range of services. We offer both inpatient services and outpatient services. Under the outpatient services, we have specialized clinics that run twice a week, and those are on Tuesdays from 8 a.m. to 5 p.m. And we also run the same clinics on Thursdays We have daily general outpatient clinics that runs from Monday to Sunday, and we have emergency services for those who come outside the normal working hours. We see them through emergency, and that is where they are received in the hospital. So the pediatric services run 24/7. And then the inpatients, we have two different wards for the inpatients. We have the general pediatric ward that admits from 1 month of age to 12 years of age. And then we have the newborn unit. The newborn unit basically admits all babies from birth to 1 month of age.
Okay, thank you, Dr. Sheila. I'll also call upon Sister Moit to talk about our neonatal care unit, which provides services to our newborn babies.
Thank you very much, Dr. Mary. In our NICU, this is the admission wing for the babies that are born 1 day to 30 days of life. And this one was established in 2006, of course, after realizing the need that the babies should be separated from their mothers to be catered for in a separate room. By then, this was taken up by Dr. Albert Kambusha. He's the one who established it. And in our NICU, it's a 24-hour service. We have a bed capacity of 18 beds, of which we have 3 incubators. That one caters for the low weight babies. Then we have 5 radiant warmers, which caters for babies that require warming. We have 5 baby cots, and we have 5 kangaroo mother care beds, where we have to stabilize our babies and train mothers on how to take care of these low birth weight babies when we discharge them. We have a staffing rate of 3 specialist pediatricians, and we have a medical officer on station 1. We have 3 intern doctors on a daily and 8 nurses that cover the unit. Our shifts are distributed into 3, that is every 8 hours, at least you'll find the ward is covered by a nurse at least and a doctor. When we need consultation, then we shall always have our doctors on ground. We admit on capacity on a daily, we have 30 babies. Then average in a month, we admit 145 babies. And we have 3 sections where we have those ones born before arrival. We separate them from the other babies. Then we have the term babies also in a separate room. And we also have where we put our premature babies. This we did to do infection control and prevention.
Thank you, Sister Moit. We are going to discuss some of the commonest causes of admission in our neonatal care unit. And I want to invite Dr. Sheila to take us through some of the commonest causes of admission in our neonatal care unit.
Thank you very much, Dr. Mary, for giving me this opportunity. Now, the commonest causes of admission into the newborn unit at Masaka Regional Referral Hospital is actually prematurity. And by prematurity, we mean these are babies who are born before time. They are not yet ready to come out. And that means many of their systems are immature to handle life outside the womb. So this presents a lot of complications. And among them, we have neonatal sepsis or infections in this newborn. The other cause of admission is, other than the neonatal infections, we have what we call birth asphyxia. And basically, when we say birth asphyxia, we mean this baby was tired during delivery. So they come out with a lot of complications, and it's probably the reason we bring them to the neonatal unit to help them survive. The other cause of admission is many abnormalities. Children who are born with abnormalities that probably occurred during the time the baby was being formed in the womb. So briefly, I think those are our common causes of admission into our newborn unit.
Thank you, Dr. Sheila. As she has presented to us, prematurity is one of the conditions that causes a lot of morbidity and mortality in our children. It's attributing to one of the reasons why we are admitting these babies and some of the reasons why they end up with complications. So today we are going to focus on prematurity. Our discussion is going to mainly based on what are the causes of prematurity, how can we prevent it, and how are we managing prematurity in our region, and what are the challenges that we are facing. To start off, I will start taking us through some of the causes of prematurity. Prematurity is when a baby is born before 37 weeks of gestation, and a baby born below 37 weeks, that baby is called a preterm. And in the Ugandan setting, the lower cutoff is at 28 weeks. So a baby born from 28 weeks to below 37 weeks, that's a baby born preterm. But in other more developed settings, the time has come down to as low as even 20 weeks or even 24 weeks, depending on the medical advancement of technology that they have to support this newborn baby. We are going to take a short commercial break, and when we return, we are going to discuss some of the causes of prematurity and complications. Thank you.
This message is from the Ministry of Health with support from partners.
Welcome back from that short commercial break. We are still here with you, the team from the Pediatrics Department of Masaka Regional Referral Hospital, and our discussion is mainly on prematurity. As we left before the break, we wanted to talk about some of the causes of prematurity. To start off, some of the causes of prematurity include infections like malaria. We have maternal conditions like severe preeclampsia, that's very high blood pressure in a pregnant mother. We have conditions like diabetes, decompensated heart disease in a mother. We also have conditions where the baby is getting tired. We have conditions that affect the baby, and that includes things like severe oligohydramnios, rupture of membranes, if the mother's membranes have ruptured and they've lost most of the fluid surrounding the baby. And we also have placental conditions like abruptio placenta, issues to affect with the positioning of the placenta in the mother's womb and leads to bleeding of this mother. So these are some of the reasons why a baby could be born preterm. And I will hand over to my colleagues to discuss with us some of the complications that are associated with prematurity. I will invite Sister Amoit to take us through some of the complications that we are facing in these babies that are born preterm.
Yeah. Thank you very much, Dr. Mary. Among the complications associated with the prematurity, most common, we get difficulty in breathing. This is because these babies are premature, like we have seen there, and all their organs are not mature enough to support them by themselves. So you find that in most cases, most of them don't have that fluid that surrounds the lungs to allow the lungs ride properly and expand to allow normal breathing. So they get difficulty in breathing. Secondly, we have also feeding difficulties because these babies are premature. They have very small abdomens, I mean the stomach, and in that case, they get intolerance on most of these feeds. They take in very little, and sometimes they don't tolerate it. So we find difficulties, and we have to really monitor them. And in our unit, you find that when a mother is feeding, we are calculating and we are supporting her. And in most cases, when we have enough staffing, you find that the nurses do the feeding to make sure we don't cause complications in these babies. Then we also have the risk of infections. These babies, the system is premature, like we have said, so they easily get infections, and when they get these infections, it is very difficult to get them out. It's also another complication that comes with these babies. Then they also have issues of temperature control, because their temperature control centers in the brain are premature, so they cannot control their temperatures on their own. That is why we saw in our introduction of our unit, we have radiant warmers which support these babies to get warm. We have the incubators that work as artificial, the artificial womb for the baby, and we also take an emphasis on the kangaroo mother care units and the beds where we put these babies to acquire warmth from the mothers. Thank you very much.
Thank you, Sister Moit. Like she has nicely put it, this baby that's born preterm, most of the organs of the baby have not yet matured. So we are bound to have problems with the brain, problems with the lungs, problems with the heart, problems with the intestines. And because most of these parts are still immature, we end up getting the child developing all the complications she has talked about. And most times we need specialized equipment, specialized drugs to be able to handle all these complications. There are quite many, we've mentioned a few, but those are some of the things that would want you to always put in mind when you're managing children who have prematurity. Thank you. As we've mentioned, temperature control is one of the challenges that is one of the complications that is faced by our children. Like we said, most of the organs are not yet mature, so is the skin of this baby, and they tend to lose a lot of heat. So I would like to call upon Dr. Sheila to expound a little bit more on how this complication affects the children and what we can do to manage the babies with prematurity.
Thank you very much, Madam Moderator, for giving me this opportunity. Now, the preterm baby has a lot of challenges maintaining their body temperature, and it is one of the commonest complications we get in our neonatal unit, especially on arrival. Now, our new preterm baby is, because the brain is immature to regulate the temperature, it basically depends on the environmental temperature that is surrounding it, and that is the temperature it adapts to. So when you expose the baby to the environment which is cold, the baby actually becomes cold. And once the baby is cold, so many things do not go right, including producing their own sugar within the body. So, and once the temperature is low, it increases the chances of the baby dying. And if you put them in an extremely warm environment, they actually adapt to that temperature. So usually our advice is cover the baby, wrap them well during transportation. We actually encourage them to, during transportation, the baby and the mother should be transported skin to skin. So we place the baby onto the mother's chest, with the baby only having a diaper or a pamper and the head covered with a hat, what we call the kangaroo mother care. And we tie this baby onto the mother's chest. And the mother is encouraged to drink warm fluids to keep her skin warm, and that actually, in essence, keeps the baby quite warm, and this baby arrives safely. I submit, Madam.
Thank you, Dr. Sheila. In addition to that, there's a tendency to want to overcover babies in our environment. It's always advised whenever you're to cover your baby, you just cover one layer excess of the mother's clothing. For example, if a mother is putting on a blouse and a jacket, those are 2 layers. If you're to cover your baby, the baby would need to be covered with 3 layers. But in our setting, we tend to cover these babies a lot, and sometimes that can cause accidental suffocation in our babies. So as we take care of both the preterm babies and at the same time the term babies, we need to watch the way we cover our babies so that we do not cause accidental suffocation in these babies. So we shall move on to some of the challenges that we are facing as we are managing our children that are coming in from the various facilities. I will hand over to Sister Moi to take us through some of the challenges that we are facing in our region as we care for these preterm babies that would want the community to get to know so that we can have better survival of our preterms.
Thank you. Dr. Mary, our moderator. Among the challenges we are facing with our babies in the neonatal unit, we are getting babies who are arriving late to the neonatal unit. Sometimes you find that a mother gives birth in the village, say she has not been able to come to hospital to deliver. And then in the village, they'll see the babies crying. Of course, they don't have things to take baby's parameters, like taking the baby's temperature, taking the baby's weight, to establish if really this baby can stay at home. There is that delay that is created there, when they are arguing, let's go to hospital, let's not go, we shall manage from home. So they take a long time to make decisions, and they come when the baby has started having difficulty breathing, baby is very cold. That delay to make a decision to come to hospital is complicating our care in these babies. Then there are also cultural issues. For instance, when a mother gives birth to twins, and we have seen that our twins are born before their term, they take cultural issues that they have some cultural things they have to perform on the babies, especially in Africa. Twins have to go with a lot of things, such things. These ones make the mothers delay, and sometimes even they don't come. They come after the baby is really yellow, babies breathing really difficult, babies cold.
Okay, so thank you, sister. We are going to put a pause on that so that we can go for a commercial break. When we come back, we shall expound more on some of the cultural challenges that we are facing in the care of these preterm babies.
This message is...
Welcome back from that commercial break. We left off talking about the challenges that we face in the care of our preterm babies, and we had stopped at the cultural issues. I would like to hand over to Sister Moit to take us through some of the cultural issues that are affecting the care of our newborn babies.
Thank you very much, moderator. Yes, we left when we were still talking about cultural issues, and among them, we have issues with babies with yellow discoloration of the skin, what we call jaundice medically. You find that culturally people believe that they can treat this using herbs. You get a baby that is smeared all over the body with green, and they believe by smearing this they are managing the yellowing of the body. They are covering the baby and masking. So the baby comes with a severe illness. We also have cultural beliefs of applying several things on the baby's cord when it is still fresh. For instance, cultures apply cow dung. They spit on the baby's cord stump. And also we have herbs that they apply on the baby's stump, which are not sterile. These ones cause infections in our babies, and they come when they are very sick. There is also what we call false teeth. Culturally, people believe they can have healers, people who extract these teeth. They use aggressive means when extracting these teeth, and they are crossing from one baby. They are not sterilized. They cross from one baby to another, transferring infection from one baby to another baby. These babies come when they are very sick. Let me hand to Dr. Sheila to expand more on the culture.
Yes, among the cultural practices, we have caregivers who actually believe, sometimes they believe this illness is not medical. They believe it is some kind of spiritual, and they need to go to probably traditional healers or spiritual leaders to have their child improve. So you find them insisting on having their child taken out of hospital, which is actually very detrimental to the health of this child. And yes, before coming to hospital, there are those who believe, actually start from the traditional healers themselves. So that makes them delay to come to hospital. So by the time they arrive here, they're actually quite ill. And that is so dangerous for the newborn. I would like to hand over to our moderator.
Thank you, Dr. Sheila.
Thank you.
Still in challenges, like we've mentioned, the cultural and behavioral. In our setting, we have a communal way of everybody coming to welcome a baby back home. So we keep our baby in the neonatal care unit for close to 2 weeks, close to a month. And once we discharge this baby, within 3 days, the baby is back to hospital with infections. So there's a practice of everyone coming home to visit the newborn baby, and we always want to discourage that. We want to make sure if a mother is discharged, at least to limit the number of people who are getting in close contact with these babies. Like we've said, their immunity is still developing. They've not yet acquired the good immune system to withstand a number of infections, and we end up readmitting these babies with septicemia as a result of some of the behavioral practices we practice at home, where everybody comes to visit the newborn baby and even carry the baby without a mask, without washing their hands. And also, if you request them to do all that, they will see it as something that is a bit discriminative. So some of these behaviors affect our babies in the management, both in hospital and also while at home. And in hospital, we still see people sneaking in herbs into our neonatal care units, and they are giving babies these herbs. They are, like Sister said, they are putting them on the baby's cords, and sometimes this disturbs our management process, and these babies acquire infections, which sometimes are difficult to treat. We are going to move on ways in which we can prevent prematurity in our babies. I would like to welcome Dr. Sheila to take us through some of the prevention strategies for preventing against prematurity in our babies.
Thank you very much, Dr. Mary, for giving me this opportunity. Now, the preventive measure of prematurity actually starts much early during antenatal, or what I would even say before conception. The mother needs to plan the pregnancy. And by planning the pregnancy, you need to start. There are medications you start even before the mother is pregnant to prevent abnormalities that would arise in the baby. So there are certain deficiencies that probably the mother has. It is recommended to start folic acid 3 months before conception. And in our population, we see that many of us, or many of the mothers actually do not follow this. Probably the first time you're going to meet the mother is when she is pregnant during antenatal, as the guideline states that a mother is supposed to have at least 8 antenatal visits during pregnancy, but many times you meet them probably at 4 or 5 months when they have passed the first 3 months, which is quite dangerous to the unborn baby. So we advocate that mothers are supposed to come to hospital even before conception and follow the recommended guideline for antenatal care. They are supposed to have the regular checkups, the regular investigations we do during pregnancy to prevent prematurity as a cause of neonatal complications. I would like to hand over to Dr. Mary.
Thank you, Dr. Sheila. As she has nicely mentioned, most of the neonatal illnesses or illnesses that happen to babies below 28 days of age require good antenatal care. If a mother has attended antenatal care, chances are high that she may not get a baby who's going to fall sick in the immediate 1 month of birth. So we need to make sure that these mothers attend antenatal, as Dr. Sheila has said, and not only attending. In our region, we still have mothers not attending antenatal adequately. Averagely, a mother should attend antenatal at least 8 times. Previously, it was at least 4 times, but going by the previous guideline of 4 times, still 60% of mothers in our region are attending antenatal care 4 times. So we really need to call upon all the various stakeholders to join us to ensure that these mothers are encouraged to attend antenatal so that we are able to prevent most of these conditions that affect newborn babies. And the other thing we need to encourage our mothers is you don't go to antenatal to just get an antenatal card as a gate pass into a health system. Please attend antenatal as one of the reasons why you want to have a safe delivery and have a healthy baby, because there are quite a number of things that get checked during antenatal. They check your blood pressure, they supplement you with folic acid to prevent you from having a child with abnormalities. A mother is usually given iron tablets to ensure that this mother does not get anemic. They always follow up on the growth of the baby while the baby is still inside the mother's womb. In case of any complications, they are detected early, and if there's an intervention that can be given, this intervention is given and the baby grows very well. We still have mothers who come and they deliver twins as a surprise. If a mother has attended antenatal, such a thing would not happen because the mother would know in an antenatal scan that she should be expecting twins and she would prepare for 2 twins, but we still get people who get surprised at birth. So that shows that people are not attending antenatal adequately. And we really want to call upon all the mothers to attend antenatal, and we also want to call upon the spouses. If you have a wife or a girlfriend or a partner that is pregnant, we want to call upon all men to support their wives, their partners, their girlfriends, to attend antenatal and also be there during the time of delivery. Because some of these things, we've not expounded a lot, but some of these things that can cause problems to newborn babies include things like lack of transport. So you find this pregnant lady does not have transport to arrive in a health facility on time, and then it can complicate the delivery, and also she ends up having a baby with complication. Before we move on, in the next segment, we are going to talk about the admission process in Masaka Regional Referral Hospital Neonatal Care Unit. I want to thank my colleagues that have joined me in this talk show. And shortly, we are going to go for a commercial break, and we'll be right back.
This message is from the Ministry of Health with support from partners.
Welcome back from that commercial break. We are still here with you, a team of pediatricians and neonatal care nurse from Masaka Regional Referral Hospital, serving the Budu region. Next, we are going to talk about admission, the admission process of these preterm babies in our neonatal care unit. I'll call upon Dr. Sheila to just take us through some of our admission processes on how a baby reaches the neonatal care unit and what are the systems that are in place. Over to you, Dr. Sheila.
Thank you very much, Dr. Mary. As we highlighted earlier that Masaka Regional Referral Hospital and the neonatal unit admits babies from all over the region, the Greater Masaka, and the surrounding districts of Mpigi, Butambala. We admit both inborn and outborn babies. By inborn, we mean these are babies who are born within Masaka Regional Referral Hospital. Once they are noticed that they are born before time, they are brought to the neonatal unit for assessment. We also get referral into the unit from the surrounding districts and health centers. They all come to the neonatal unit and they are admitted in as outborn. We also get referrals from traditional birth attendants. Especially if the baby is not doing well, they still refer into the unit and we do receive them. Some of the babies come in through the emergency medical services that is actually within Masaka, Greater Masaka. We have a call center, and there is a call center number that usually the patients can call in and the ambulances picks them from where they are.
Okay, thank you, Dr. Sheila. I want to call upon Sister Moi to take us through some of the challenges. What are the problems these babies arrive with? We've heard that Masaka Regional Referral is giving services to people as far as Kalangala, as far as Mpigi, as far as Sembabule, Bukuma Nsimbi, Diantonde, Rakai. So there are some challenges definitely that we are getting with the transportation of these babies. I would call upon Sister Moi to tell us some of the problems that we get as these babies are coming in, and then I will take us through the EMS system of the Regional Referral Hospital.
Thank you very much, Dr. Mary. Most of the challenges we get with babies who don't come through the right transportation channels include hypothermia. These babies are transported in most cases on border. In the process, the person transporting the baby is only wrapping the baby in very many clothes. Like we talk to these babies, we say they cannot produce their heat because their system is premature. This baby will not produce heat even if they put a whole suitcase of clothes. Instead, they are going to suffocate the baby. So they assume by putting a lot of clothes, the baby is getting warm. But you find that they get to the facility, actually to the ward, when the baby is too cold, and it takes us a lot to get that baby out, to get the baby back to normalize. And also, some babies come with severe respiratory distress, which is difficult in breathing. because some of these babies are picked, they require oxygen during transportation. But if you're not coming by ambulance, you're not coming maybe by private means where we can put an oxygen cylinder, this baby is going to deteriorate more and they arrive really very sick. And worst of all, another complication we get is that we sometimes receive dead bodies because of transportation issues during referrals in.
So in 2018, the coffee project that was through the support of the South Korean government to the Ugandan government, the emergency medical services in the region were boosted, and we have the first state-of-the-art call center in the region. This call center comprises of staff and also a fleet of ambulances. This call center mans over 28 ambulances in the region. We've come together as different stakeholders. We man government ambulances, we man private ambulances, we man UPDF, police, Red Cross, and also some PNFP hospital ambulances. So we came together, we've trained ambulance drivers, we have emergency care technicians in these ambulances, and these ambulances are also tracked on the GPS system. So these ambulances are always ready to respond to any alert call in the community. And some of these alert calls include accidents. Since we are positioned on the Mbarara Masaka and Masaka Kampala Highway, Masaka Mutukula and Masaka Sembabule, Masaka Bukakata highways. These highways experience a wide range of road traffic accidents, and this emergency call center system ensures safe evacuation of these accident victims. In addition, we also attend to maternity calls and also newborn care calls. So whenever a health facility delivers a preterm baby, they call our emergency care center. We have both toll-free and non-toll-free numbers, and the call center team alerts the receiving department to prepare for the arrival of this child. And through the same system, we always give advice to the lower health facility on what to do, ensure that baby has received some glucose, ensure that the vitals of the baby have been taken, the temperature, ensure safe transportation, ensure that the baby is put in kangaroo mother care before they are being transported to the system, to the hospital. Like I've told you, we are receiving children as far as Kalangala, and there are times when, if you do not coordinate it very well, they may come and find the ferry has gone and the baby has to wait at the landing site for the ferry to return. So if we don't have a safe transport system, we may end up losing this baby. So we want to call upon all our stakeholders, our health facilities, to ensure that we utilize the emergency call center system to ensure that we have safe transportation and better outcomes of our newborn children. So this call center has a sister call center that has been stationed in Butenga Health Center 4, and we usually man all emergencies, not only maternal child health, but we also man road traffic accidents, fires. We man any other medical alerts that are in the community, and we always dispatch the nearest ambulance. We use the GPS system to position the alert call, and we always alert the nearest ambulance to respond. And if there's need for backup, we send more ambulances from the various regions. And that's why some of the people who have had a chance to come to Masaka Regional Referral, you find an ambulance from Chanamukaka, an ambulance from Chabakuza, and you find people asking, where are the ambulances of the regional referral? The ambulance system works as a team. The nearest ambulance always responds to the problem. And no matter whether it's private or public, we always work as a team with the support from the Ministry of Health and Emergency Medical Services and also the coffee project. Thank you, our viewers, for having stayed with us throughout this show. Before we wind up, I would like to call upon my colleagues to give us their last piece of advice. Over to you, Dr. Sheila, then Sister Moit, and then we shall close.
Thank you very much, Dr. Mary, for giving me this opportunity. Our topic has been prematurity and its complications. And the best treatment for prematurity is actually prevention. And under prevention, the take-home message is let's adhere to antenatal. let's go there even before conception. So recommended is 8 antenatal visits, so let's ensure that we go there even in the first month, not only to book a card and book a place. Thank you.
Sister? Okay, thank you very much, Dr. Mary, our moderator. I want to put emphasis on encouraging mothers to deliver in healthy facilities. And if it came to you and you are unable to reach the healthy facility to deliver in a facility, please deliver your baby like it has come to you. But make sure you bring this baby to the hospital for evaluation. And when you're transporting this baby, we are advising that please make sure the baby is warm. And how we are doing this, we are saying we are putting the baby on skin to skin with the mother, and we cover the baby, then we bring the baby to the hospital for evaluation and management. Thank you.
To wind up, I would like to remind us that the neonatal mortality or neonatal deaths are one of the reasons why we are failing to bring down the death of children below 5 years. So I want to call upon all of us, the community members, the relatives, the fathers, the mothers, to know that we all have a role to play. If you know you have a relative who's not attending antenatal, please encourage them to attend antenatal so that we can prevent most of these newborn care problems. Ensure that we prevent prematurity, ensure we prevent infections in newborns, and we are able to improve on our quality of services that we give our mothers so that we can have healthy babies. This evening, we've been the Masaka Regional Referral Hospital Pediatric team, and this has been the DOCtalk Show, and thank you for listening and viewing us. Have a good evening.
This
UBC, inspiring Uganda.
A very good evening and a warm welcome to our second edition of UBC News Tonight on this 28th day of November 2024. I'm Loreen Masika Kazimoto to bring you this evening's news bulletin. And we start off with our first headlining story this evening. President Museveni has urged East African leaders to prioritize economic and political integration, warning that failure to unite could jeopardize the region's future development. He made the remarks during a meeting with Right Honorable Amason Chinji Jeffa, the Speaker of the Senate of Kenya, and his delegation at State House Entebbe. President Museveni expressed disappointment over the reluctance of some East African leaders to embrace integration, which he said has slowed the region's progress.
Allow me to express our appreciation for the hospitality accorded to us so far. Mzee tumeshukuru. We actually felt home away from home. You know, walking around the city, and we just felt we're back in Nairobi. The brotherhood, the sisterhood, it's amazing. So allow me to say thank you so much for giving us that kind of, hospitality. As I was